Hi, this is Dr. Lani Simpson, and tonight we have a guest, a very special guest. I've interviewed her several times before. Her name's Dr. Jennifer Schneider, and I really want to I want to share with you one thing here real quick so we can understand who we're listening to tonight. She is, yeah, I guess in my point of view, she's a giant in the field of pain management. She speaks at various institutions all around the country. And she's earned her PhD of molecular genetics from the University of Michigan and her MD from the University of Arizona College of Medicine. And she's certified by the American Board of Internal Medicine and the American Society of Addiction Medicine. And she's a diplomate of American Academy of Pain Management. She has also written many papers in medical journals on this subject, as well as a book for the general public called Living with Chronic Pain. So welcome, Dr. Schneider. Now you can unmute yourself.
Thanks.
Yeah. So, one of the things I want to talk a little bit about why I decided to interview Dr. Schneider now, and it was because, as some of you know, my partner had a severe fracture about 2 months ago, and our experience with getting and not getting the right medications that she needed, and a lot of the myths that are out there regarding medications when we need them. So understanding this is very helpful for us because as we're aging, many of us are having to have surgeries or we might fracture. Some of you are already in that situation. And Dr. Schneider knows personally very well about pain herself. And because this is an osteoporosis group, maybe you might want to share your story regarding your hip fracture and how that happened.
Sure. So this was 2003, and I was visiting my daughter in New York, and I got on the subway, the train was just pulling out of the station, and I was hanging on to the strap and twisted, and I just shifted my weight from one leg to the other, and I felt my right femur cracking. I could hear it crack. Out of the blue. I was a healthy, middle-aged woman, exercising every day and everything, nothing wrong with me, no osteoporosis or anything. Some osteopenia, but my bones were in pretty good shape. I fractured, and it turned out that when I got to the hospital, I had fractured my right femur, and nobody understood it. Now, I had had pain in that femur for a couple of months before and had gone to see an orthopedic surgeon, and they had actually done a MRI of that leg, and they found that I had some uptake in the upper part of the femur, and the radiologist said it had to do with obviously I had some childhood disorder or whatever. Nobody knew anything at that time about atypical femur fractures. And so they were completely mystified. I was hospitalized at the Hospital for Special Surgery in New York, which is one of the premier orthopedic hospitals in the US. And they were completely mystified. And I thought, could it be the Fosamax, which I've been taking at that time for about 6 years. I started around 1995 when it was just started. It had just been approved, so I'd been on it for like about 6 years, and I thought, could that have had something to do with it? But the doctors there said they don't think so. But I stopped taking it anyway. So it was several years later. So anyway, I needed to have a rod put in the femur, and the usual. I was in an inpatient rehab unit in New York for a couple of weeks, and then after about 3 weeks, I got back home to Arizona. It was several years later that I read an article in a medical journal about 5 or 6 cases of femur fractures, or some of them were other kind of fractures in the pelvic area, And the author of the article found that what they all had in common was that there was a big problem with their bone density and the bone structure. And she hypothesized that it could have been due to the Fosamax. And I read that article and I thought, that's it, that's it. So that was
Well,
sort of the beginning of my career.
well, and the thing is that you took Fosamax, because you thought it was a good idea, but also they were giving it back then as a prevention for osteoporosis. And even back then, just understanding basic bone physiology, it never made sense to me, because if you are really successful at shutting down osteoclasts for too long of a period of time, that's probably not a good idea. But we don't.
Exactly.
But it's still a rare fracture. So we do think now that there are, which would make sense, there's genetic differences in all of us that would make some people more prone to getting those fractures. We don't know what that is. But I have some people who've been on Fosamax 15 years, never had a fracture, so not recommended. And I've been interviewing Dr. Miller about this. We won't get on this anymore, but he said he doesn't see very many anymore, where back maybe 10 years ago, he was seeing a lot of these atypical femur fractures. So
this is good. I think what it is that doctors are becoming less, they're more knowledgeable and less willing to provide it to people for prevention.
Yeah.
For one thing.
Not for prevention anymore, thank God.
And that's really the main thing, that it's still, it's a very effective drug for treatment, but you need to realize that 3 to 5 years, it should be all that you would take it, and you have to stop. So that's another whole story. But I only kind of got getting on the right track because I had read that one article. And then I started, and then what happened is I was interviewed by a writer for the New York Times, Jane Brody. She's still doing this many years later. And as a result of that, I started getting emails from women all over the country who had had similar experiences, such as what she wrote about in her article about me. And she had a large picture up, which took up like half of one page of the New York Times with a picture of my famous femur fracture. And I ended up starting an online support group of the women who wrote to me, because they had questions and I was interested in their experiences and all that. And it's still going on. It's been, I think, 11 years now. And there've been probably 300 or 400 that I've written. I think only about 150 or something are still active, but it's still a support group that's going on.
That's great. Okay, well, let's get, I also have other interviews with Dr. Schneider regarding more of the same, this type of topic here. But I want to say that neither one of us is opposed to the use of bisphosphonates. Fosamax is that. We're opposed to, we want wise use. You have to do your proper lab work, all that. You guys have heard, this group has heard a lot of that. So anyway, we'll just move on to the pain part, because that's what this is about tonight. So I'm going to go ahead and share your slides now.
Okay.
Okay.
So I decided to start by, well, let me preface it by saying that I also teach a remedial and proactive course to prescribers of opioids. And most of them are told by their medical board that they've done something wrong with their prescribing and they have to take a course such as mine. So I've been doing this now for about 10 years, and I get to know a lot of what's going on in the community all over the country. And it's just amazing that the myths that I'm going to be telling you about now are ones that most of these doctors believe are the truth. And so do all of the remaining people in the US. The vast majority believe these 6 statements that I'm going to tell you are all wrong, and I'm going to tell you very briefly why. And the reason, why each one is wrong, but the reason I even want to start with this is I think it's going to really influence your understanding of how I answer your questions. If you're not thinking in advance that why is she pushing, prescribing doctors to prescribe opioids when they do these awful things to people. So that's why I'm going to just tell you about these 6 misunderstandings. So the first one is that a patient who develops withdrawal symptoms, if he or she stops their opioid medication abruptly, is addicted to that opioid. And most people actually believe that. And I would imagine that, some of you who are listening to this do too. And I want to explain to you why this is wrong. So let's look at the next slide. All right. So here's the thing. Withdrawal symptoms are not indicative of addiction. They're not part of the definition of addiction. What they are is they are the definition of a phenomenon called physical dependence. And what a physical dependence means that your body adjusts to opioids. And you know, it's a good thing they adjust to it, because they adjust very quickly to things like respiratory depression, which is why you can increase the dose and people can be walking around on a dose that would be fatal to someone who took it and hasn't been on it. Because their body has adapted to it. So the body adapts to several of these things. It's also true of nausea. Luckily, people adapt very quickly to that. But it means if you stop it suddenly, your body has changed, and therefore you're going to have these withdrawal symptoms. And as it turns out, most people who are on more than 2 weeks of morphine, of at least 60 milligrams of morphine, which is not a high dose, or drugs, some other opioids that can be stronger or less strong than morphine. And that's why we talk about the concept, which some of you may have heard of, called morphine equivalence, which is how much does that translate if we're just talking about the classical opioid, which is morphine. So most people who are on more than 2 weeks of this drug at that dose become physically dependent. That means precisely the definition is that if you stop it, they become they develop the withdrawal symptoms. So this is nothing to do with addiction. Very few people develop addiction de novo, meaning they weren't addicted before, now they're on the drug and they become addicted. But almost everybody becomes physically dependent. So most of us, if we're on at least 60 milligrams, are going to have withdrawal symptoms. This does not mean we're addicts. All right, next slide. Okay. Now, let me just review what I just said about physical dependence. It's a property of opioids and of other drug classes. For example, if you are on well, let me just say other drugs, some heart drugs, for example, Inderol, drugs like that. If you stop suddenly, you're going to have some withdrawal symptoms. So it's not just, and corticosteroids is another one. If you're on prednisone, 60 milligrams of prednisone for an allergic reaction or asthma, every doctor knows that you taper people off. Why do you taper people off of prednisone? Because otherwise they're going to have withdrawal symptoms, which can be fatal. It's worse than what happens with the opioids. So in other words, physical dependence applies to all kinds of drugs, including opioids, including corticosteroids, including beta blockers, and it's easily preventable. You just taper. Next slide. All right, so the next myth, I anticipate that a patient on chronic opioids will become addicted. Now, this is related to the previous myth, and I'm going to talk a little bit more about that. So let's see what the reality is on that one. Next slide. Okay, so to review, most patients on chronic opioid become physically dependent, but few become addicted. So now what is addiction? So let's look at the next slide. All right, this is what addiction, right out of the Diagnostic and Statistical Manual of Mental Disorders, which is the book that physicians use to diagnose, that psychiatrists have written to diagnose psychological disorders. And so it used to be called addiction, but instead they've changed the name to opioid use disorder. This version of the DSM, the Diagnostic and Statistical Manual. So it has 3 elements. One is loss of control, which means compulsive use. And that means if you start using this drug, it's very hard to stop. And in fact, you continue doing more. This is true of any addiction. People who are food addicts, for example, part of what they have to do to try to recover is you don't bring home your favorite foods or your favorite cookies or, whatever that you're going to eat too much of because it's hard to stop. That's what this is about. That's this first element. The second is continuation despite adverse consequences. Something bad is going to happen, but it doesn't stop you from doing it. Again, if we talk about somebody that can't stop eating cookies, why do they worry about stopping? Because they know they're gaining weight, but they still do it. So that's adverse consequences. And the third is preoccupation or obsession with obtaining and using the substance. That means that it becomes the most important thing in your life, and it's what you're thinking of. And when it comes to drug addicts, it's like they really ignore other things like family relationships. And when you're talking about people who are gambling addicts, they will gamble their bank account that they've put into saving up money for their kids' college expenses. And if they're in a gambling situation and they need more money to continue gambling, they'll throw in the kids' college account. So that's called adverse consequences, and they're still doing it. And it also shows that that is the most important thing in their life, is this activity, which is gambling, or the drug. So, next slide. Now, how likely are people actually to become addicted? I said that everybody has physical dependence, but not addiction. So this is an article from 2017, 4 years ago, in a very important journal, the Journal of the American Medical Association. And this study, what they did was they took a bunch of people who had chronic pain, and they who were not on opioids, and they started half of them on, this is a study, so they started half of them on opioids, and then the other half with similar pain, they didn't start on opioids, and they compared how likely were they to become addicted, addiction being defined by the slide I just showed you. And they found out, and this was a very widely publicized article, because it showed you were 15 times more likely to become addicted to opioids if you had been started on them 3 months ago than if you hadn't. This sounds terrible, but here's the problem with it. It didn't say this in the abstract of this article, but you see, when you're comparing the risk of one thing to the risk of another, this is not considered the absolute rate. We don't really know how much it actually happens. We only know how much does it happen compared to something else. So if you take a bunch of people who have chronic pain, who are not put on opioids, and 3 months later you find out how many of them become addicts, the answer is extremely few, because why would they suddenly, for no reason at all, become addicted? And now you compare them with a bunch of people who were started on opioids, and 0.72%, in other words, less than 1%, 90 days later, had become addicted. Well, don't you feel very differently about starting a person on opioids, or like yourself, let's say, if you're told that you're 15 times more likely to become addicted versus if you're told that you have a less than 1% chance of becoming addicted? Lani, does this make sense to you?
Yeah, absolutely. And plus the 3-month thing, a lot of people, when they're put on them, are only put on them for a short period of time, like
right.
2
But
weeks.
This study was specifically for people who want it for
3 months.
But the reason that I mean, normally when I'm talking to a non-doctor population, I don't give these kind of fancy article descriptions, but this to me was such an incredible example of how easy it is to mislead people. And when this was publicized, and I actually first saw this article when I read it online, and I thought, oh my gosh. And then when I actually read the article, and I said, well, wait a minute, this is not the absolute risk. This is the comparative risk. What is the actual risk? It turned out to be less than 1%. So depending on your bias, you can give results of something in a very misleading way. So it's things like this of why so many doctors, and I would say the vast majority of doctors, believe that the risk of people becoming addicted, if you just put somebody on who's not addicted on it, they think the chances are 95% you're going to become addicted, whereas in fact the chance is between less than 1% to a maximum of 5%, depending on the studies. So that's going to be enough of the data, but I wanted to show you this because I know that for people who are educated like you, Lani, this will be a very impressive article published in one of the most highly respected journals in the world.
Yeah, I suggest people get a hold of it.
That's why I have the reference there. Okay, next one. If a person develops more pain on a given dose of analgesic, the most likely reason is the development of tolerance. And so in other words, you will hear from most doctors, I anticipate that patients will become tolerant to a given opioid dose. Now, Lani sent me Dr. Simpson. Should we call each other doctor or first?
Yeah, no, Jennifer and Lani.
That's fine, because you called me Dr. Schneider to begin with. But
Oh, I'm sorry.
I believe it. Okay. So Lani, you asked me to look at some article that was explaining opioids, and it actually is very reasonable, except it talked about that you have to be concerned about tolerance. That is such a misunderstanding. Now I'm going to talk about what tolerance really is and why most doctors and most everybody else in the world thinks that you're going to need more and more. Okay, so let's look at the next slide. So the definition of tolerance is that you need more of the drug to get the same effect. Or another way of looking at it is that if you continue with the same dose, you're going to get less effect. So the problem is when it comes to opioids, they have more than one effect on the body. They have pain relief, which is, of course, the effect you want, but they also have sedation, nausea, and constipation, which are definitely things you do not want. And it turns out that when it comes to opioids, people develop tolerance differently to these four things. To sedation and nausea, thank heavens, and that also goes to respiratory depression. You know, the reason that people die when they don't know what they're getting, like people who buy it on the street and then they drop dead, it's because the sedation or the respiratory depression. And then nausea is another thing. And but after a very short time, like a day, you start having less of that. And pretty soon you can be on a dose that's 100 times what'll kill somebody. And you can be walking around driving a car and you're doing just fine. On the other hand, tolerance to constipation, everybody knows doesn't happen. If you're on if you're on an opioid, you're very likely to become constipated, and you have to treat the constipation all the time, preventively, hopefully, because it's not going to go away. The question is, do you get tolerant to pain relief? Do you need more medication? If you're on a certain dose that works the first week, 6 months later, are you still going to have the same dose? If you're not, then does that mean that your body has said, well, I need more and more to get the same effect? Well, let's go to the next slide. You're muted.
Hang on here.
All right. Okay, so yeah, next slide. So the fact is that tolerance to pain relief with opioids is uncommon. So I myself was a doctor my specialty was the use of opioids for chronic pain, because I'm also certified in addiction medicine. So I could do the risk assessment and knew what I was doing. And what I found, and what every doctor who's got the kind of practice I do finds out, patients who are stabilized on a given dose of an opioid typically continue on the same dose for years, unless there's some change in their underlying disease state. For example, if you have chronic pain due to osteoarthritis, which I have, and in fact, I've had surgery on my back because the bones kept growing. This is what happens with osteoarthritis, and impinging on the spinal canal, so the nerve couldn't get through there. This kind of thing. So things got so bad that I had to have surgery on that. So if I'd been on opioids at the time, I certainly would have needed more, because now I was having more pain. But it wasn't because so it wasn't because I was on opioids. It was because the disease was progressing. Okay, next slide.
Okay, let me just ask you a question here.
Sure, Lani.
So you're kind of blowing my mind here, because I had these beliefs as well in terms of tolerance and addiction. I had no idea that it was less than 1% of people, and that just outlining that difference between addiction and the physical, the
Physical
mind versus the physical.
Right.
And that yes, we're going to have those symptoms, but they can be managed if you're taper it down.
Right.
So what about long-term? Maybe you're going to get to this, but you mentioned about long-term use, like people who are in chronic pain. Doctors don't want to put people on these for long-term. But what kind of damage does that do to the body, and where? Like certain drugs. What's that?
We're going to get there.
Good. All right. Okay, should I go to the next one?
Yes. So why is tolerance misunderstood? Well, the fact is that the reason it's misunderstood is because doctors who prescribe opioids for chronic pain inevitably end up increasing the dose. Now, so why? So isn't that tolerance? Well, not necessarily. Here's 3 reasons why you're likely to see a person needing more opioids. First, when you start them. So you and I, Lani, were talking about earlier before this program started, what to do when you first start the drug. You don't know how nauseated a person is gonna be. Now, I get terribly nauseated. I found out the first time I broke my leg and I needed opioids. I mean, they had to start an IV and give me high doses of water because I was throwing up nonstop. So what you do to minimize that, you always, no matter what you think, how bad the pain is, you always start with a very low dose because you want to assess how nauseated they're going to get and how sedated. And then when they're okay on that dose and they're not nauseated or minimally and they're not sedated minimally, then you can increase the dose. So when you first started, you know, in the first week or whatever, or 2 weeks or 3 weeks, whatever, depending on where you have to increase the dose to, you're going to be increasing the dose. So that is a very common thing at the start. Now let's say what happens, and this is another thing that happens that every doctor that I've had in my course misunderstands. You have a patient who you've increased their dose twice. Now they're at a dose that they say works. Then you tell them, okay, great, here's a month prescription for that dose that you said had decreased your pain from 10 out of 10, which is the maximum, to 5 out of 10, which is a 50% increase, which is considered a very desirable outcome. So they've been to see you 3 times, you've increased the dose to whatever they say has dropped it to 5 out of 10, and then you give them a month's supply and they come back a month later, and most of the time they're gonna say, I have more pain. And the typical thinking is they've developed tolerance. But here's what they're missing. There's 2 goals of treating chronic pain. There's to reduce the pain, and then there's to increase their function. The thing that everybody forgets about is function. Now, with your job, Lani, you think a lot about function. So, but I'll tell you, most people don't. Most doctors don't. So the thing is, if a patient, when they come back after a month, you're going to be asking them several kinds of questions. One of them is, what's happened to your pain? Well, they've just told you it's increased. And the second one is, well, what has happened to your function? And then what you're hoping they're going to tell you is, I can do a lot more. Well, why is it that I'm much more comfortable sitting than walking? 5 minutes when I'm walking, I'm in pain, all right? The point is that pain increases when you do more. So people with pain are going to be less functional. And a major goal of treating chronic pain is to improve the patient's function. So what happens if my physical therapist has me walking 15 minutes with my walker around the loop of my subdivision every day. And I can tell you that I plan to take that walk only when I know I can come back, and then I read the paper on the sofa. That's my strategy, because by 10 minutes that I've sat and been reading the paper, that pain is gone. So the point is that you have more pain when you're more functional. So now you come back after a month and you're having more pain because you're doing more. The pain may not necessarily decrease as fast as mine does. I'm just lucky. I'm very, very lucky about that. But the point is, being more functional comes at a cost. That's why people with chronic pain tend to sit around and do nothing, whereas you want them to do more. So now the doctor has 2 choices. You say, okay, fine, I'll increase your dose again. Not because you've become tolerant, but because you've been more active. Or you can say, well, I'm not comfortable prescribing more than that. Now, what happens if you say I'm not comfortable prescribing more than what was helping you a month ago? What is the patient going to do? Lani?
Yeah, they're going to stop.
Yeah, they're going to stop doing all that stuff. Well, I'm not going to be walking around I'm not on opioids, but I'm saying if that was the reason I could walk around, I would say, what the heck? I'm not going to do that walking anymore. So you're going to get back to where you were before. I mean, it's ridiculous. So
yes, we were talking before this too. You were saying like starting off on a slow, low dose and building up so you can avoid that nausea. And then also thinking about the size of the person, 95-pound person versus a 300-pound person. And also, if you're in an emergency situation, you're in the hospital, you've got that broken hip or the broken leg or whatever it is, and you're in excruciating pain, they're going to give you a high dose typically then, or do you say, can you just give me half or something?
no, you don't want to do that, because the idea of reducing the dose because a person has a side effect, and a lot of doctors will do this. Oh, you're constipated, we're going to reduce the dose. Well, that's absurd, you know? And that's essentially the same kind of thinking. What you do is, like, because I'm one of those people that I'm extremely, I always, my kids used to laugh at me, you're a pill you're a pill pusher while you know, they make you so nauseated and whatever. So the thing is, obviously I'm not a pill pusher, but what I'm saying is I do try to educate people about opioids. But so the thing is, it is helpful to know how you react. So when I go to the hospital, and I'm about to have surgery or whatever, I explain to them, I'm very sensitive to opioids. So, you know, first of all, if you can give me something that is not an opioid, that's great. But if the pain is enough that I need it, then you need to give me something like Zofran, which is a drug that's absolutely the most effective one I know for nausea. You're muted, Lani.
Does Zofran actually work if you're taking?
I think it depends on the dose. I mean, of the opioid. If it's really high, it might not work, and then you just might have to put up with it. But at least the fact is they're going to be aware that this is a problem. And I mean, in my case, when I was post surgery, and or even I guess before surgery, even when I was in so much pain, they just had to increase my the IV drip I was getting, because I wasn't getting any fluids by mouth. I couldn't drink anything. So, you know, I just had to have a lot of fluid IV to get me through that initial part. But the thing is, it helps if they know that this is going to be an issue. Okay. They're going to give you, and then the other thing is, from then on, whenever I have a procedure like a colonoscopy, which at my age, you know, you have to have every few years, and or some other procedure, there are options to how they can treat you. And so the very typical thing is fentanyl that they give you, fentanyl for the procedure, IV or something. But it turned out that propofol, which
yeah,
accidentally I had for some minor procedure, and I woke up after the procedure, I didn't know what I'd had, but I knew that instead of, I had arranged for somebody to drive me home because I knew I would be throwing up nonstop, and I planned on being miserable for days and whatever. I get up and I felt I'd been through a good night's sleep. I felt so normal.
I love propofol. I mean,
propofol is fabulous.
And that's what they usually give people now, pretty much, even if you get an endoscopy.
And I can tell you that the last time when I had the procedure, I had a family member that had colon cancer, so I have to have, you know, I mean, I've had to have colonoscopies every few years. But anyway, so the last time I had it, and I had a new doctor, I asked them that the anesthesiologist that they're going to use, what were they going to use, and they talked about like the usual fentanyl stuff, and I said, no, I need to go to an anesthesiologist who's going to do propofol. So in terms of the strategies, if you know that you happen to be someone who's very sensitive, the first time it's going to happen to you, obviously. The first time, you know, but after that,
well, I would absolutely recommend that if people are getting, you know, things like a colonoscopy or an endoscopy, or even I had surgery on a melanoma, I had propofol.
Right.
It was great. Worked great.
It's just amazing. So I remember right after I had propofol, it was right after, what's his name, Michael Jackson died of a propofol overdose.
Yeah.
And which of course he shouldn't have had it at home, because it's a drip and you have to have an anesthesiologist watching you every second, because you have to really regulate exactly how much propofol drip goes to you. And it didn't happen with him, and that's why he died. But I understood immediately what happened to him.
Yeah.
But anyway, so let's continue here. So the second item was that let's go back to that. We had one more. So the second one I just finished saying was that increased activity, which is a desired outcome, is a very typical reason why once you get to an initially effective dose, a month later or so, when you see them next time, or the doctor sees you next time, you're going to need more. And this doctor has to understand that, because if they say, no, I won't prescribe more, or you're getting tolerant to it, or, you know, whatever, that's a misunderstanding. They need to increase the dose, because really otherwise you're going to be less functional, and then it's like crazy. So the third one is if you're doing fine, and let's say a year later, you're saying, well, it worked great this year, but now I'm starting to have more pain, whatever. And osteoarthritis is a very common example of a situation where that is likely to happen. It's because you've had disease progression. And osteoarthritis doesn't stop getting worse as we get older. That's just part of getting older. I'd rather get older with osteoarthritis than not survive to be old, you know. So anyway, so that's the end of this slide. This is the only slide that I spent a lot of time on, but this whole issue about tolerance is very important. I mean, everything I read in the medical letter and in other very respected journals, they're full of this statements that are misunderstanding. All right, the next one is that opioids don't work for chronic pain, just for acute pain. So I want to say something about that. Let's see what the reality is. Now, you'll hear this from doctors and from everybody all the time. So the real reason that this is true is that there are very few long-term studies of patients on opioids for chronic pain. You just don't have high quality information where they've got a control group. Now, who usually sponsors studies of drugs? It's drug companies, you know, and these studies are expensive. And to do a study for 4 years on patients for a drug is so expensive, it doesn't happen. You know, their idea of long-term is 90 days. That's about it. So you're not, when you look things up, you're hardly going to find any articles that talk about patients who've been on opioids for 2 years, 3 years, 4 years. These studies have just never been done, except one study. All right. And why is it? Well, it turns out that anybody who's a pain specialist like me, who specialized in opioid prescribing, because I would be sent patients by their doctors that have tried everything else. We all have had a stable of patients who were on the same dose for a long time. But like I say, they have not been on one of these high quality studies. We've got a control group and all of this and this. But we know that it happens. So the only published study that even approaches that is one that I wrote at the time that I retired, because I kept excellent records, because I also do a lot of medical legal consulting. I knew exactly what dose my patient had been on, every single dose, every single time, for however long I was seeing them. And this article talks about 198 patients that I was seeing at the time that I retired, that I had been treating for at least 1 year. And they were being treated for an average of like about 4 years, long term. And what I found out is that more than half of them were, and back then in those days, we were using much higher doses than we are now. So that most of these patients were on well over 200 milligrams a day of morphine, which like you just don't see anymore. But in the old days, it was okay because it's safe. We're going to go into that in a minute. But anyway, so I co-authored with a guy who worked for a university and therefore had a whole statistics department to do crunch all the numbers. And we published it in this, in 2011 Journal of Opioid Management. If you're interested, Lani, I can send you a PDF of the article.
Yeah, I'd like that.
These patients were being treated for an average of over 4 years on doses of over 200. And at least half of them were on the same dose for all that time. It's the only study I know where they've actually studied to show that you can continue on it for a long time, that you don't, it's not the expectation that you're always going to be increasing the dose. So my last thing, and this came out of actually an editorial in New England Journal that I decided not to bother you guys with, that there's a difference between there's no evidence of, which just means it hasn't been studied. I mean, which really means there's no known evidence. In other words, there's a big difference between you know, it doesn't exist versus we don't know about it. And that's what you have to understand. When they say that, well, no long-term studies have shown any benefit, that's because no long-term studies have ever been done. Next slide.
Okay. Do we know how many more slides? Because we're...
Yes, there's just a couple more.
So I would, if we're going to do the questions.
Right. So I just want to get to there's just a couple. One has opioids has severe side effects, including organ damage. All right, let's go to the next slide. they don't really have organs. The most common side effects are nausea and sedation or respiratory depression, and they go away within days. Another common side effect is constipation, and that's you just, if a patient is started on an opioid, the doctor has to talk to them about how to deal with constipation. It's going to happen. And also common is low testosterone levels in men, and that occurs in most people on opioids. And the solution is to treat them with testosterone replacement. I don't have time, obviously, to go into that, but the main point is opioids do not damage internal organs.
Well, that's an important thing.
Right, exactly.
And I'm going to add to the laxative thing. My group knows a lot about magnesium. I talk about it a lot because it's such a great thing to use for constipation.
Yeah, and that too, right. So the last one is that the main cause of the increasing opioid overdose deaths is the opioid prescribing by doctors. This is what everybody believes, and it's believed that the solution is to make doctors and other prescribers stop prescribing. And I just want to show you this slide, which is how many, the average opioid dose per day in the past 10 years from 2006. You see it's decreased. Doctors have been, because they've been gone, persecuted and all that, and have learned to be more cautious, less prescribing of opioids. And now let's see the next slide. At the same time, look what's happened to overdose deaths. Now, this is really dramatic. The prescribing has decreased, but the opioid deaths have increased. Now, that doesn't make sense, right? If it has to do with prescribing. Got it? Well, it turns out that really, what's really gone up is not the prescribed opioids, but rather heroin or any opioid. It's really gone up. It's mostly because of misuse. So let's go to the next.
Or street availability. But you know what, the argument that they have for that is that they'll put people on TV saying, I got started, my doctor got me started. And then I was addicted, and then I went out and bought it on the street.
Well, they don't buy it on the street because they're addicted, because like less than 5% become addicted. They go on the street and buy it because they're desperate and don't get it in terms of their pain. So let's go to the last two slides, which is a very brief summary, and then we'll be done. Okay, so that's, go on the previous one. The one after that, and the one after this. Next one. Oh, yeah. Okay, so first of all, the opioid deaths combine several groups of people with different reasons for having died, all right? First of all, there's a confusion between addiction and physical dependence. So the belief is that doctors are turning all their chronic pain patients into addicts, and therefore if they die, it's because the doctors have turned them into addicts. That's the first false belief. Now, also, heroin and illegal fentanyl are unregulated, less safe, and more likely to produce overdose deaths because you have no idea what you're getting. Fentanyl is almost 100 times as powerful as morphine. So if you have fentanyl in the heroin that you buy, you don't know what you're getting. So a lot of these deaths have to do because they bought these less safe drugs. Why did they do it? They did it because as fewer prescription opioids became available on the street for addicts, more addicts substituted heroin, and now they have more total deaths. And at the same time, more patients who were desperate because they weren't getting the drugs from their doctor for their pain. They were going on the street and buying the same stuff that they don't know how much, and they were dying. So let's look at the slide before, because I think I had the two backwards. Yeah. Treatments, and the other thing, and this is really going to lead to what we're going to be talking about, the treatment plans tend to focus on opioids rather than to get to know the patient and the role of trauma. And that would be physical or emotional trauma that they have had, like childhood trauma, by the way they were treated, or they were sexually abused or whatever. Also, depression and anxiety. It turns out that a lot of the opioids are very good at treating depression and anxiety, and people start to take it for pain, and then they want to continue taking it even when the pain resolves, because they think that the reason they feel better in terms of depression and anxiety is because they have less pain. But the real reason is that their unrecognized depression and anxiety were treated. So now they're feeling better. See, that's a big distinction. And finally, that effective chronic pain treatment requires a team effort, but insurance companies often won't pay for important modalities such as behavioral health assessment and treatment. So that's the end of what I wanted to say. Now I'm ready to answer any questions you might have. Okay, you're muted again, Lani.
Coughing, so I have to mute every now and then. Okay, so let me get to the questions. So Frida asked about steroid. Oh, we'll get to that in a second. Is there a cheat sheet regarding pain meds and how to get what we need if we need them?
Okay, cheat sheets is something for simple things. Like you can have a cheat sheet for what to do when you've got right lower quadrant pain in your abdomen, which, I mean, you don't have to be a doctor to realize that you're going to be thinking about your appendix kind of thing, But when it comes to all of these issues of chronic pain, there's no simple way. So no, you have to get educated.
Okay. Nancy says safer and or stronger alternatives to common OTC pain medications, Aleve, ibuprofen, etc.
So what are the alternatives to, first of all, let me tell you that the most common cause in this country of liver failure, do some of you know what is the single most common cause of why people need a liver replacement in the US?
Okay, those of you who are in the chat, what is it? Let's see if you guys can start answering some questions. So what's the question again? What's the most common cause of liver failure?
Of having to have a liver replacement.
Yep, it's Tylenol. Very good, Christy.
It's Tylenol. In other words, it's not an
opioid.
It's not an opioid. It's a drug that's considered to be much safer than opioids. But in fact, it's the major cause of people having to have their liver replaced. And of course, the thing is, Tylenol is in so many over-the-counter medications that you might not even realize what you're getting. So if I have patients who are on a lot of Tylenol number 3, which is Tylenol with hydrocodone, and they've been taking 20 a day because they have so much pain. And when they come in to see a doctor, the doctor's concern is not going to, if a patient drove to your office and said, I'm on 20 pills of Tylenol number 3 a day, or of Percocet, which is oxycodone and aspirin, your main concern is not going to be the opioid they're on. It's going to be in how much, in the fact that they're in a very high dose of Tylenol on these drugs. So the Tylenol can be more dangerous than opioids in that.
So the hydrocodone, there's, I guess, maybe even more than 2 that I'm aware of. One is with Tylenol, and the other one is with home atropine. And that was put in because it's a drying agent or something like that, so people would not abuse it. So it doesn't have any Tylenol in it. It just has home atropine. What do you think about home atropine?
I've not heard of it being combined with Tylenol.
No, they're both.
But you can combine it with things. A lot of the opioids now have a deterrent in them that is added. So if you crush it, you also get some other drug that makes you have bad side effects. So it's very common to add some other drug to try to.
Yeah, that's a real drag that you can't get it without Tylenol or these other things that actually are more harmful than the opioids.
That's right. And that's one advantage of the extended release ones, which another misconception is that the extended release ones that
extended release what?
Opioids. It's mistakenly believed that the extended release opioids are more dangerous than the immediate release. The ones that are in higher doses, but you only have to take once a day or twice a day, versus having to take it every 4 to 6 hours. It's widely mistakenly believed that those short-acting ones are safer, but it turns out, we don't have time to go into it, but that's absolutely the opposite of the truth. It's another misunderstanding.
So how much Tylenol a day? Because this is a pretty important thing.
3 grams.
And for how long?
3 grams indefinitely a day is safe.
3 grams is safe?
Yes.
Tylenol.
Yes.
And for how, and at what point is it not safe? Because how much is, say, in the hydrocodone?
If you have, it has nothing to do with hydrocodone. If your question is how much Tylenol is safe, I'm saying if you have a normal liver, 3 grams a day you can take forever of the Tylenol. You can take 2 extended release 500 milligram Tylenol 3 times a day forever. That's the highest dose.
Because you were saying that when people were taking the hydrocodone with the Tylenol, which I don't know how much Tylenol is in it, maybe
350 milligrams.
350.
In other words, if you take 10 Tylenols, you've exceeded if you take 10 Tylenol with codeine, you've exceeded
Gotcha.
your
Okay.
maximum.
All right. Wow. That's, I mean, it's just so incredible to hear. I didn't know this stuff. And so I really personally want to thank you because, I just didn't know that the opioids were less of a problem to our organs and things like that.
Now let's talk
Some of these
about
over-the-counter things.
ibuprofen. Let's talk about NSAIDs.
Yeah, let's talk
NSAIDs
about
are
it.
a major cause of people getting hospitalized for bleeding, for GI bleeding.
Especially as we get older.
Right. So the fact is that that's why the American Geriatric Association, in all these years in their position paper on treating older people for pain, have said that you should avoid NSAIDs.
Okay, well, let me ask you this. Like, say, for
Like
instance,
Motrin and Advil, all
Yeah.
that stuff.
yeah, let's say you've got a knee condition that you're
Mm.
probably going to have
Mm.
replacement, but you're taking something.
Right.
Would you actually recommend something like low dose opioid over chronic use of the ibuprofen or Tylenol? I'm just curious.
Well, I've been taking 2 grams of Tylenol a day, especially at night. And, pain is often greater at night because you don't have the distractions.
But wouldn't you rather have an opioid now that we've talked about it?
No, because they tend to make me nauseated.
Oh, right.
But then I get used to it. But I can't just be taking it PRN. It doesn't work very well because if I
Gotcha.
take it and a week later,
Okay.
okay.
All right, I got you. Okay.
We always have to weigh the issues with these drugs, but I guess the message that you and I are giving is that it's a mistake to assume that drugs like Tylenol and NSAIDs like Motrin and Advil are going to be safer.
Okay. Now, what do you think about? Okay, so I want to say something about this first, and then we'll hear what you have to say.
All right.
But the whole thing about cannabis, and it's the latest.
Sure.
It's the latest cure-all. There is some good evidence. I don't believe it's going to help with osteoporosis. There's no studies that I'm aware of that actually show that. But in terms of pain, I mean, there is some evidence in that regard, right?
Well, I have a definite opinion, and I'm always asked that in the classes that I teach for doctors who've been required to take my course because of their prescribing, and there's always a question about cannabis, especially in the States. Even my state of Arizona recently made it legal for optional use, rather than for medical use, recreational. But so there's always a question of what do we do? See, the biggest problem with cannabis products is that they are illegal federally. And now, increasingly, states are making these cannabis products legal, both for medical marijuana and even recreational. So the question is, if the federal guidelines say it's illegal and the states say it's legal, which one applies?
Yeah, I would guess the federal.
Well, this is the problem. You're exactly right. The stricter guidelines apply to rules. So if you live in a state where these drugs, where cannabis products are legal, it is still federally illegal, and therefore the bottom line is they can go after you. Now, here's the problem. For things to get approved by the FDA, they can't be illegal. They have to be legal. So the wonderful thing about getting approved by the FDA is drugs that are approved by the FDA, you know exactly the contents, the quantity, that there aren't any contaminants and stuff like that. That's what you need in order to get, approval for the drugs, okay? So if you don't have that FDA approval, you can't do good tests. Because if you're going to do high quality studies, you have to give patients a certain dose of a product and then compare it to half the people that don't get it. But it's been impossible to do that because it's very hard to obtain identical quantities of a product which isn't approved and therefore it's not controlled.
But the other thing too is I think probably, and this is true with other things, is that there's no patent that they could probably get on it, right? So that's a disincentive for the pharmaceutical industry.
So in other words, there's illegal things and then there's financial things. And they both apply when it comes to cannabis. You can't get um, exactly, from a financial perspective, you can't get the patents. But in addition, you're not going to be able to get the sources to be able to do the high quality studies, which means you have to compare
Okay,
the
well,
identical.
so let's just, we already get that. Now, what about it? So I can
So
get it here,
So
but
therefore,
I can't
anybody
take.
can get it.
Yeah,
And
but what are we getting? Yeah.
And you don't really know what you're getting. So you have to hope that, I mean, a lot of these places in Tucson where it's legal say that they work with the lab that makes sure that the content is the same and blah, blah, blah. And
Standard,
trust
right.
them.
Yeah, and do you believe
Trust,
that?
you see what I mean? So if you trust them, then you try it and you see if it works. I mean, there are a lot of things that we try, and if they work, we continue. And I'm in favor of people giving it a try. And I'm in favor. The solution, the first solution, in my opinion, is to change the scheduling, which is with, you know, how much you have to look it over. One is legal, two, you have to have lots of rules about it, and then it goes up to 5, which is, you know, and anything else for what to 5. Right now they're 1, which is the most severe thing. That's illegal. If the federal government changes it to 2, that's going to immediately allow the drug companies to create the same version of the drug in every prescription, and to do the studies and to do those high quality studies. Meanwhile, we have to go on what experiences are. And I've certainly talked to a lot of people. I talked to a friend in California at the time that cannabis became legal there and not in Arizona. And her doctor refused to prescribe opioids for her. And I said, how are you doing? Isn't this terrible? And she said, no, I started going and getting, you know, marijuana, and I'm doing great. So I'm all in favor of people trying it.
Okay.
It's just that we don't really know what's in it.
And that's the problem, you know, that has it been
That's the
sprayed
problem.
or who knows what. But yeah, you just got to do your best to get a reliable source.
Right.
And then Marie Claire asked a question, and I'll start with this one. I'll start answering this. But steroid injections for patients with low bone density, risk, benefit, frequency, alternatives too. So steroid injections have been shown to cause localized bone loss, and maximum 3 in an area, I would say. But yeah, I mean, it definitely can cause localized bone loss, and you have to consider that wisely. So I think it depends on the health of the bone. If somebody has borderline osteoporosis, they're probably fine. But a -4 in the spine and getting, you know, epidurals, again, you got to just look at each case individually. But yes, it can cause a problem. And then the alternative to that would be probably if you're in severe pain enough that you're trying to get a steroid, maybe it is opioids. And Kathy says, I recommend checking out drrunhealer.com for more details on cannabis. So I guess Kathy feels they're a good company. I don't know anything about them, but she's in our group. She's a thinker. And Katie wanted to ask about neuroplasticity. I honestly don't know much about it. Do you, in terms of effectiveness and all of that?
Well, my understanding of neuroplasticity is it's the concept that your nervous system can be affected by experiences. And it's exactly why we talk a lot about in treating chronic pain, why you need to, when you have chronic pain patients, especially the ones that are having trouble getting better with how you're treating, you really have to look at what happened in their childhood. You really need to have a behavioral health assessment to see what traumatic things could have happened to them, either psychologically or physically, because more and more pain doctors are coming to realize that the impact of trauma, whether it's physical or emotional, can actually make physical changes in the nervous system, because the nervous system is plastic, meaning it can that it can change, and so therefore you have to be aware of that when you're considering the treatment, and that's why you really have to look at behavioral health. You also have to understand that the nervous system does react to signals that it gets, and a classic example that I love to use in my teaching is the idea of mirror therapy. I don't know if you're familiar with that.
Let's say that again.
Mirror, like a bathroom mirror.
Mirror therapy. Yep.
Mirror therapy for people who've had amputations. they often have a lot of pain, and they complain that the pain is in the leg that's
The phantom,
gone.
yeah, the phantom pain.
Phantom limb pain, right?
Yeah.
They have phantom limb pain. And it turns out this has to do with neuroplasticity, because what it means is that their pain perception in the brain has changed, because they're no longer receiving those pain signals from their left extremity because it's gone. And so the brain creates signals to make up for that. And it often creates pain signals, which is why the person with the amputation believes that, feels that the pain is coming from a part of the body that they don't really have. I mean, it used to be thought that it's because maybe the nerve was cut off at the knee, and so the edge of the nerve is hurting. But really, the source of it is the central nervous system.
And that is such a fascinating.
Right. And so, therefore, you have this really bizarre sounding treatment, which there's articles in the medical literature, and it's now totally accepted by people who are experts on phantom limb pain, which is the treatment that they try first these days is they have the person sit on a table with the legs stretched out. And when you're looking at the table, what you see is you see one leg that goes down to the foot and the other one that stops at the knee. Well, now you put a mirror between the two legs with a shiny side facing the good leg. And now you look at the mirror, and what do you see? You're sitting there sitting on the table, and there's a mirror between your legs, like a bathroom mirror, a tall one, and you're looking at it on the shiny side, and you're seeing two legs. One is the reflection of the leg that's missing, but you're seeing two legs. And what happens is, I don't remember exactly how long, you half hour or whatever, you do that. The brain is fooled into thinking that you've got two legs, and those signals in the brain change.
Wow.
And what I have not seen in follow-up is how long it takes before you have to repeat this in order to continue not having the pain, because after all, you're not going to be getting signals as soon as you take the mirror away. But that's a great example of the existence of neuroplasticity, that the fact that your nervous system can change from experiences, from what it's perceiving. Now, I don't know at all what this person meant by asking the question. So yeah. I don't know if I even addressed what her concerns were. But
well, I think she just wanted to know if you used it and valued it. And I think
she must have had
that
some
is a
reason
definite
for asking
yes.
a question, which I have no idea what it is.
Yeah. The other question, well, there's a couple more and then we'll end, but Marie Claire asked about options for nerve pain resulting from fractures with nerve compression.
Okay, so that's actually a great question, because of course, I mean, I teach a 16-hour course where I teach all of these things, and so there's a lot we couldn't deal with. And I do want to say, I want to make sure to say that a mistake that a lot of doctors make is that they think that all you have to do is throw pills at the patient. And specifically opioids. Whereas the fact is that if you are a competent chronic pain doctor, you have to understand that you need physical therapy. You need, I mean, sometimes obviously if you're so impaired you can't move, that it may not be possible, but to strengthen your muscles or whatever. But basically, most people with chronic pain need physical therapy because they have decreased their function. They're doing less. The muscles, therefore, are deteriorating, and therefore things just get worse and worse. Physical therapy, all these modalities, including biofeedback, including behavioral health, all
acupuncture.
Acupuncture, absolutely. And when it comes to chronic pain, things like EMDR can be wonderful. We don't have time to go into it, eye movement desensitization, reprocessing, but there are all these crazy sounding treatments that we know they work because we've seen it work, it's, and studies have proved that. And it's true of mirror therapy as well. So it's not just about prescribing pills, but in terms of pills that are non-opioids, specifically if you have identified a pain as being neuropathic, and meaning that there's something wrong with the nerves, that the nerves have been damaged or cut or, made it, whatever. There are drugs, there's a whole category of drugs, which are drugs that are used for seizures that are effective for neuropathic related pain. And that we use all the time when we realize that as soon as we understand that a type of pain is neuropathic, and that would include back pain going down your legs because the nerve is compressed from the spinal canal being shut down or decreased.
Stenosis, yeah.
Spinal stenosis. I lose words sometimes.
Oh, it's okay. You can finish my sentence. I'll finish yours.
Okay. So anyway, so if you've got spinal stenosis and things like that, well, you know that it's a neuropathic type of pain. Then if you use drugs like gabapentin, pregabalin, it's a really good idea to try those. Now, the reason that a drug like gabapentin is often considered to have failed is for two reasons. One, that you need a much higher dose for neuropathic pain than you do for seizures.
So what is that dose? 300?
Well, you can go up to maximum of about 3,000 milligrams a day.
Really? Yeah,
yes.
Gabapentin.
You need at least 1,800 milligrams a day to be effective. There are articles in the Journal of the American Medical Association for peripheral diabetic neuropathy and shingles, 2 articles that got those drugs approved for those 2 things. And basically it's worth trying for any kind of neuropathic pain, but you need at least 1,800 milligrams. And very often doctors that don't know this will get the patient up to 1,000 milligrams, and then they say, and it doesn't work for the patient, and they stop. Well, the fact is they didn't go up high enough. And the second reason is that gabapentin makes people sleepy. If you get them up to 1,800 milligrams, you might get so sleepy that you just don't want to take it anymore. So that's the main reason that drug fails. But if somebody goes to a doctor and says, I tried gabapentin and it didn't work, most doctors say, okay, and they don't prescribe it. But that's wrong. The first question is, what dose were you? Because either it was too little or it was too much,
Yeah.
So you have to know what you're doing with these drugs.
So I really would love to have you back again, and maybe we can just, and maybe we would just focus on the mirror thing or something. I mean, you have so much, so much information, and I'd like to talk to you about that. Maybe we would just focus on the mirror, and some of these other things that people don't necessarily think of, and how to find a really good chronic pain specialist.
Sure.
I'll have that be the last question. How do you find a good chronic pain expert?
Well, the problem is in this current political environment where the misunderstanding in the government is that doctors are causing the opioid overdose crisis, which, as I've explained, is wrong. Doctors are really being pushed to prescribe less. And it's very, very hard. In my community right now, there's like one doctor who actually is willing to prescribe opioids for chronic pain. And there used to be a dozen. And I get letters all the time from patients who say, I don't know what to do. And I can't give them any advice, because the fact is that right now there's an incredible amount of political pressure on doctors to prescribe less and not to take on pain patients. And a lot of doctors simply refuse to use opioids in their practice. I mean, it's ridiculous, but they have notices on the walls of their waiting room saying we don't prescribe opioids for chronic pain. And there is very little we can do about it.
Okay. Well, Jennifer, I really want to thank you. And I think you've put out so much information. It's going to take, I'm going to have to listen to it again so I can absorb it. And I would love to have you back, and maybe we can break it down into some, categories, because it sounds like also we do have to do this other work, perhaps like the mirror technique and things like that, because we're not getting some of these other things that we may need. And maybe that would be 20% of the pain. If we can get it down even 20%, 10%, that's a big deal.
It is.
Okay. Okay. And they're saying fantastic presentation. Excellent. And yeah, thank you. And we'll talk soon.
Okay. Bye-bye.